Welcome, welcome everybody. Welcome to the second in this series on mental health and fundraising. Hi, Dr. Fiza, good to see you there. Hi, Catherine.
Hi, everyone. Welcome, welcome.
Hey, Daniel. We still have a minute to the top of the hour, Christy, so we'll hang on a sec.
Oh, absolutely. Yeah. Maybe you can give it a minute over. Happy with that.
Sure. Welcome, everybody. Good to have you coming and joining us for this important series on mental health and fundraising. Hi, Bob. How are you? Give us a wave. Hi, Fiza. Lovely to see you, Doctor.
Thank you. Yeah.
To be with
How
you.
are you, Chris?
Doing well.
Yeah, okay.
Hi, everyone. We'll just give it a minute and then we'll get started.
Hi, Andrew. Nice to see you there.
Hi, Chris. Nice to see you.
Welcome.
Great to see so many familiar faces.
I know, it's nice, isn't it? And we can always borrow money off them if we can't raise any, right? Hi, Sandra. Good to see you.
Hi, Chris. Great to see you. Nice to be here.
Thank you. Hi, Orla.
Hello. Hi, everyone.
And hi, Pavel. Nice to see you as well.
Nice to see you too.
So, Christy, I think we can probably get cracking. What do you think?
Sounds great. Go ahead.
Great. So my job is simple today. I'm the chair of the mental health collaboration for Catalyst 2030 and a board member of of Catalyst as well. And it's my job to welcome all our collaboration members today. Lovely to see you all. And those of you who are not yet members, this is the ideal time for joining up to Catalyst at no cost. And then becoming a member of this collaboration, the mental health collaboration. We are recording today, and if that's a problem, please turn off your video, but otherwise feel welcome to keep it on. Today my job is to say that this is the second of the series that we're in at the moment in mental health and fundraising, and we have our wonderful moderator who is the designer of this series and the program. So a particular warm welcome to you, Christy Civetta, and a warm vote of thanks to you. Just to say that you are the founder and principal of Be Lumen. You have worked in the field of mental health and fundraising for a number of years, and of course health more broadly as well. And we look forward to your moderating this session very much indeed. And the first thing you'll do, I know, is introduce your panel. So I'm going to hand over to you straight away. Warm welcome to you, Christy, and thanks.
Thanks very much, Chris. So nice to be here. So delighted to be a part of this series and to be a part of this collaboration with Catalyst 2030. So thank you very much for having me. So as Chris said, I am the founder and director of Be Lumen. We are a boutique consultancy, works with organizations who are socially minded, nonprofits, for-profits, and we support them with company strategy, commercial strategy, things like that. We mostly work in mental health. That's primarily where my background lies. And the most of the work that we do is fundraising. And we've worked with our organizations to raise over 80 million to date over the last few years. So we're taking all of that knowledge and we are putting it into a webinar series designed by myself. You'll meet actually some of my team in webinar 3, which will be quite cool. And this is the second, as we said, of the 3 phases. In the first one, we talked a little bit about the fundraising landscape. We had some wonderful funders join us to talk a little bit about their own experiences. And in this one, we're going to start getting a little more granular. We're going to talk about costs, and we're going to talk about impacts, that fun word called cost effectiveness. We'll talk about what it means, we'll talk about practical tips for it. And then in the final webinar, we'll talk a little bit more about how to develop and deploy a fundraising strategy. And we'll talk a bit more about that at the end of the call today. I'll share some more details on that. At any point, if you have any questions, throw them into the chat. We have some wonderful folks in the call that will pull them out for us, and we'll take a look at them at the end when we do some audience questions. So what are we talking about today? We know that there's a huge need of mental health. 250 million adults in the world experience depression. Only 25% will ever receive any support, right? And we know that funding is a massive gap. So that's why we're doing this massive, series on fundraising. It's not just how to help you fundraise, but it's also thinking about, how can we as a collective increase the amount of funding that's in there in the world for mental health work? We know only 2 to 4% of global development funding actually goes to mental health. So how do we deal with that? How do we think about that? And today we're talking about cost and impacts, cost effectiveness in many regards. What is it? Why is it important? What are some tips of how to think about it, how to write about it? There is a huge spectrum when it comes to talking about comparing relative costs with impact outcomes, especially in mental health, right? How you think about it, how you handle it. A lot of that will have to do with what stage your company is in, right? The maturity of your organization and what your ultimate goals are. How small do you want to be? How big do you want to be? What's your scale plan look like? And the reality of the sector is that outcomes and impact aren't necessarily standard in mental health. We've talked about that, right? It's a challenge we discussed at length in the previous webinars as well. Measurement is really difficult. And it can make it a really interesting conversation. And it puts a lot more onus on implementers, on you all, to truly lay the foundation for what it means for your work and kind of tell that to the funders as well. So that brings me to the panelists today. As Chris said, we are absolutely blessed to have such a range of experiences on the panel with us today. Implementers, health economists, researchers, fundraisers, charity evaluators. These folks have seen it all, and I honestly wish we had an entire day to talk about them and talk to them. So without further ado, I will stop talking. And I would like us, for our panelists, to introduce ourselves. We've got Colin, Barry, Nicola, and Lauren joining us. And so I'm going to start off with Colin. If you could briefly introduce yourself, but also while you do, can you go ahead and define what cost effectiveness is?
Thank you. Thank you, Christy. So my name is Colin Mangena. I'm based at the Center for HIV Research in Zimbabwe. I know it's a mouthful. So cost-effective analysis basically is an economic evaluation method or strategy to compare the costs, benefits, or outcomes of an intervention relative to an alternative, maybe data score, or a range of other competing alternatives. It basically allows policymakers to, select interventions that minimize costs whilst maximizing. Yeah.
Thank you so much, Colin. Your audio came a little bit in and out for me. I'm wondering if that happened for some others as well. I see some nods. I'm going to ask you if that's okay, if you can drop your video so we can strengthen your audio. I'm sorry about that.
All right.
That might be helpful. As it stays strong, we'll ask you to pop it back on again. But thank you for that. So if folks missed it, Colin, do you just want to say one more time who you are and where you're from?
Okay. All right. Can you hear me more clearly now?
Yes, so much better. Lots of thumbs ups, I see.
Okay. All right. Okay, great. So I will just take that again. My name is Ngena. I'm a Central Health and HIV Research in Zimbabwe. Just to define cost effectiveness analysis, it's basically an economic evaluation method. You can hear me?
Yep.
You can? Oh, okay, great. It's basically economic evaluation method that compares the benefits of an intervention relative to the status quo. It could be one intervention, or a range of other interventions that you could be comparing with. It assists policymakers to select interventions that minimize costs or that minimize resources whilst maximizing outputs or benefits. Yeah.
Right. That's so helpful. Thanks, Colin. I appreciate that. And the word cost effectiveness, I think, is thrown around a lot, but it's good to have a basis of the definition of what it truly means and what people are using it for. Barry, I'm going to hand it over to you. Can you introduce yourself and add anything else you'd like to that definition or anything that stands out to you about cost effectiveness?
Thanks, Christy, and hello, everyone. Nice to see you all here. My name is Barry Grimes. Since March, I've been the production editor of the World Happiness Report out of the University of Oxford. But my most relevant experience for this discussion is my previous two roles. So previously, I worked at the International Alliance of Mental Health Research Funders, which is a group of public and private funders, specifically of mental health research rather than implementation. And before that, I was part of the team that set up the Happier Lives Institute, which some of you may have heard of. It's a charity evaluator, a bit like GiveWell, but specifically focused on well-being. So I'll talk a bit about that later. And just to build off of what Colin was saying, I think people sometimes get a bit nervous with the term cost effectiveness, and you can get lost in the kind of the numbers and the data and the academic analysis side. But ultimately, this is a question that's about people. And if you are running an organization that's trying to help people, you want to know you've got a limited budget. How many people can you help with that budget? And that's why cost effectiveness is important, because you want to help as many people as possible. And kind of in our everyday lives, we're thinking about cost effectiveness questions all the time. We're thinking, how much does our weekly shop cost? Which kind of bean should I buy? What's the interest rate on my savings account? Which place should I put my savings? And I think about kind of mental health funding in the same way. Like, if you're going to fund a mental health project, how can you help the most people with the funding you have available?
Awesome. Thank you, Barry. Nicola, over to you. An introduction and anything else you want to add.
Yeah, thank you to you all. Can you hear me okay?
All good.
Good. So it's lovely to be with you all. I'm the founder and executive director of Jandiri, and I see there are some Jandirians on the call, so hi to you all. We are a Zimbabwean non-profit organization based in Harare. And what we do, we integrate mental health support into HIV services for children and adolescents. Really recognizing the key role that mental health plays in determining how well young people do on treatment as they're growing up with HIV. So we've been doing this for 20 years with young people right at the forefront. So services are delivered by trained peer counsellors living with HIV. And that CARDA is embedded into government as a critical part of the national HIV and mental health response. So the model's been scaled in Zimbabwe for many years and now adopted across the region in 13 countries. But a critical pathway to this scale was, of course, ensuring that we had really rigorous evidence that it improved viral suppression, HIV outcomes, as well as mental health outcomes. So we've had a really significant drop in symptoms of depression and anxiety. But that, of course, wasn't enough. There was increasing pressure and requests that we could also demonstrate, well, what does it cost and is it cost effectiveness? So really, as an implementer, we had, certainly no idea how to approach this. I'm certainly not a health economist, but we were really extremely fortunate to be able to partner with a research team, particularly Colin on this call, so that we could generate this understanding of whether this model is indeed cost effective. And then I can talk more as we move on through the call about how we approached that and what that meant to us. But it's been a critical part of our story and supporting our ability to scale this model. And yeah, really important work and very much a sharp learning curve, which I'll talk about. Thanks.
Thanks, Nicola. It'll be great to have your examples and your experience on this call along with Colin.
Sure.
Lauren, do you want to jump in, introduce yourself, and anything else you'd like to add?
Thanks, Christy, so much for having me. And just to reiterate my little pitch for Catalyst, I'm in the leadership team of this mental health collaboration with Chris, and encourage you all to stay in touch on our LinkedIn and join our group, because we have a lot of wonderful events, and particularly around fundraising. Anyway, so I'm Lauren, and then my actual job is to work on the research team at Damagi. Damagi is a technology company, and we're a social enterprise, and we build digital tools for people like you all, I'm guessing. A lot of our customers or partners are NGOs, academics, healthcare organizations, and more. And we help amplify and support the work they're doing, as well as run some of our own programs as well. A big part of my day job is actually writing grants to foundations, pitches, concept notes, and also working with our partners and customers to help explain to them how digital tools can support their either impact or reducing costs. So I think about these sort of topics, both on the impact side and cost side, quite a lot in my day-to-day work. And then just briefly as a way of background, I actually have a business degree and a public health degree. So I've learned to think about costs and impact and evaluation and research in a variety of lenses, which I think actually comes to play a lot when working on pitching one's program. These different audiences are looking at cost effectiveness in different lenses, and figuring out what lens they're thinking about is actually, I think, really helpful for fundraising. So hopefully we'll get into that a little bit more. And just to build a little bit on Barry's point about this, I agree, this is totally about people. And I think when doing fundraising, data and hard evidence is critical. I work on a research team. I write research grants all the time. I do not underplay that, but also the stories behind them to help people interpret and really understand why that data matters. So this is about cost effectiveness, which is generally, numbers and data, but I don't want to discount the stories that go alongside that either, particularly in fundraising when trying to convince people to give one money.
Thanks, Lauren. Absolutely. It's super important to pair your numbers with your stories, right? And to make sure they are appealing to multiple different audiences when you're sharing the information you need. I'm excited to dive into the conversation. I mean, I know it's already started, but I'm excited to dive in more. So let's start with a broad question. We want to talk a little bit about, let's start with challenges. What is one challenge, let's say, that you see when you're implementing or measuring cost effectiveness in mental health programs? Barry, let's start with you.
Yeah, thank you very much. So I'm going to focus more on the effectiveness side, and I think some of the other panelists will focus on the cost side. So hopefully you'll get a balance of both parts. So I think the first limitation that I see with cost effectiveness is particularly organizations at an earlier stage, they have a lot of what I call pre-post data. You survey people before the intervention, you survey people after the intervention, and then you see did people get better or not. And that's valuable data for sure, but it doesn't necessarily tell you kind of whether it was your intervention that was making the difference. And something we know a lot with mental health therapies is that a lot of people kind of get better anyway. And so even if they hadn't had the intervention, they might have improved. So you don't know for sure when you survey everyone at the end how many people got better because of your intervention rather than just other things in their life happening. Some other things that we don't really have very good data on at the moment is how long does the effect last? So in some cases, people will survey people after the intervention. You see like a big improvement in their well-being, but there isn't any long-term follow-up. And it's the case with almost any intervention, not just mental health, that kind of effects decay over time. So although people will get a boost from the intervention, it's not going to last for the rest of their life. They were likely to kind of go back to baseline. But it's important to know like how long that process takes, and that requires doing follow-up with people over a number of months or years. And then the other big gap in the data is the effects on others. So we'll take a survey of the person who received the intervention, but usually that person is kind of part of a household. And if there's an improvement in that one person's well-being, that often has what we call spillover effects, onto other people in the household, whether that's the partner in the relationship or the children. So for example, if a mother is able to kind of go and earn some more money as a result of this intervention, that money might then benefit the children and the other people in the household. So there's still a lot that we don't know about the overall effects of mental health. But what people tend to see as the gold standard is the randomized controlled trial, an RCT. And certainly, I think that should be an ambition for any organization once they kind of reach the right stage. But I think what I've seen in my experience is just because something's an RCT doesn't mean it's a good RCT. I've seen a lot of variety from very poor RCTs to like really good high quality RCTs. So if you are thinking about doing an RCT for your program in the future, it's worth taking the time to make sure it's going to be really well designed and that it's pre-registered, which means the researchers say what metrics they're going to look at before they actually start any data collection. So that prevents any bias coming in. And the other really important thing about RCTs as well is sometimes if they don't show you the result that you want, people might want to not publish it and not share it in the world. But that leads to kind of bias in the evidence base overall. So it's really important that when you commit to doing an RCT, whatever it comes out with, that you commit to publishing that and sharing it with all the people who are doing research around the world, because even something that might not show a big effect might actually provide a really important insight that helps other people all around the world. And I'll pause there, I think.
Thanks, Barry. I mean, I think that challenge you kind of kicked us off with as well in terms of the measuring of the actual effectiveness. Like it's very difficult to actually understand how effective mental health programs are. And it's something that we talked a little bit about in the previous webinar when we had a member from CRI Foundation who told us like, well, we don't know what to measure in terms of your program and your work. We don't know if it's worked or not. So you have to tell us. And that's very difficult, I think, especially when you have a certain set of standards that potentially have come out, like PHQ-9s and things like that, that were created and developed in particular cultures and then attempted to apply to others. And that's always a very difficult thing to balance through. That lack of standardization is hard. So I think you're right. We're talking about RCTs, like thinking about kind of where that data is going, where that impact's going, where that effect is going. How can we push that information out into the global space, seeing if it could help others when they're actually thinking about their own work, their own cost effectiveness, their own impacts. So it's an awesome way to kick us off. Lauren, I know you've worked very similarly, kind of in a similar set of knowledge, especially when you're writing about things like knock-on effects, things like that. Could you talk a little bit about challenges that you've seen, in terms of implementing or measuring cost effectiveness in programs?
Yeah, definitely. Thanks, Christy. So I work a large part of my work is on mental health, but not exclusively at Tamagi. And one of the things that I find harder when writing grants and proposals on the mental health topics is for some other global health areas, there really is robust core evidence for the core intervention, right? So like I was writing a proposal that involved vitamin A tablets. Like Corcoran, who's sort of the end all be all of data, was like, we should not be doing any more RCTs on vitamin A because we know it works. So any new RCTs about whether vitamin A works is a waste of money, right? So we don't have to prove vitamin A works. And while there are many, many studies around mental health and CBT and sort of the underlying things, it's definitely not as robust and not as robust across all contexts and cultures in the way that some other topics are. So that's really, I find, tricky because a lot of proposals we write is sort of just talking about how we're going to scale and implement something that's like almost without dispute. And that is sort of easier to argue the costs. Seeing the ROI of like making data collection easier is pretty simple in some contexts. But for mental health, that core is still a little fuzzy to people, even if everyone in this room probably agrees it's critically important. And the second part is exactly what you said, I think, Christy. The sort of spillover effects, as Barry was alluding to, I think are giant in mental health. And they're often hard to quantify because they take a long time to see. So we know people, who are suffering from depression and anxiety, and also the transdiagnostic nature of mental health makes this tricky because sometimes an RCT only studies depression, but it might actually also be helping people with, high levels of anxiety, but they didn't actually even measure that. But these conditions impact so many things. I mean, as Barry alluded to, income generation, staying in school and educational attainment, how you parent your children, if you're a mother who's depressed, all of these things are such a core part of improving, the outcomes of mental health, and they take a long time and are very costly to measure. So that's tricky. And that's for us a lot of times where those stories come in, because for foundations I find, or people I'm talking to, generally that stuff makes sense to them, it resonates. And so that's helpful, although the harder data is trickier to come by, particularly in mental health, I think.
Yeah, I think it's a great point. I think an awesome segue as well, because I'd love to hear a little bit, Nicola, from your team, in terms of, can you talk us through a little bit how you started to think about cost effectiveness for Jandiri? You guys are 20 years old, been doing this for a while. I probably in the early days, it was a whisper of a thought, where the money needed to go, not in an RCT, not an evaluation just yet, needed to actually get the work going, get it done. Now where you are now, you've had that experience, you've done multiple RCTs, you have this cost data. Can you walk us through like a little bit of that journey? What are some of those like initial challenges in terms of capturing the real impact on cost and on outcomes? How did you overcome them?
Yeah, I mean, I'd be lying if I said we rushed into it with glee. I mean, I think it's been I'm very, very glad we've done it. We've come out the other side, and it's incredibly helpful. But the sort of story is that Jandiri had been costed by Bill and Melinda Gates Foundation and CHAI back in 2015. And that was really helpful to have this costing data that had been done by external institutions in a really rigorous way. It helped funders understand the cost of delivering this intervention, but we wanted to go further and really measure the cost effectiveness. But of course, the challenge was we didn't know how to do that. We needed expertise and we needed money to do it. So we, at the same time, were designing the Jandiri trial, which was an RCT, to measure the effectiveness of the Jandiri intervention on viral suppression and mental health. And Barry's made my life easy talking about, the benefits of that and how to approach it. But the research team led by Frances Cowan recommended that we embed this cost effectiveness study, which felt like a bit of a gulp and a leap at the time. And she describes it as a brave move. We didn't know what we were going to find, but we spent, of note, about 3 to 4 years trying to get funding for this trial that focused on peer-led mental health and psychosocial support. And actually we finally got funding, thank you to Vive and the Positive Action Foundation. But this gave us a really rigorous study, back to Barry's point. So we, and I'll just say that we've learned a lot over the years about who to partner with when it comes to research. And we've got great examples and others that have been a learning process. But it was an incredible team of academics. So we knew it was a really robust team from multiple institutions, a rigorous design and research process. So this gave us really rigorous outcome data, which Colin could then use when doing the cost effectiveness analysis and modeling. So I think the real challenges were increasing pressure that, everyone loved the model, it was being scaled, but there was a request for, but, is it cost effective? So then when you're asked that question as an implementer, you're like, well, fine, but we don't know how to do it and we don't have the money to do it. And so it was really about ensuring incredible partnerships, financing for that. And I caveat all of this with, I understand not everybody will necessarily have the ability to or desire to do an RCT, but I think Barry's made that point really clearly. So that was sort of in a nutshell our experience in why and some of the challenges, but I'll hand over to Colin to speak more about the actual work. If he's there.
Colin, over to you if you're with us on the line. I know the internet was kind of.
Thanks, Nick.
Oh,
sorry,
great. Go ahead.
My network had dropped. So, and then I struggled to get back in, but thankfully I'm back. So can you hear me?
Yep, we can hear you.
Hello, everyone. Can you hear me?
Yeah,
Yes,
we can hear you, Colin. Can you hear us okay?
Hi, Colin, we can hear you.
Oh no, internet. Let's give it a few seconds. Colin, let us know if you can hear us. Oh, did he just drop?
I'll message him.
Thanks, Nicola. Sorry, folks. Internet, as you know, we all live in a virtual world. It's bound to happen in terms of people dropping in and out. We're going to press on while we wait for him to join us back. Lana, if you happen, or Chris, if you happen to see him pop back up onto the thread, if you wouldn't mind just giving a shout, that would be great.
No worries.
Okay. Okay, so I mean, in terms of some of these challenges, right? I mean, the effectiveness is a big piece of it, measuring those elements, the knock-on effects, and then the reality that it does cost a lot when you're thinking about kind of RCTs and bringing out particular data in order to do things like cost-effective analyses. I know, Nicola, I know that Colin was going to add a little more detail to that. Is there anything else you'd want to add on your side in terms of some of the challenges of the cost-effective analysis? I'm happy to jump forward as well.
Yeah. So once we had this amazing result and finding that when you invest in young people as peer counselors, it has a significant impact on viral suppression, their QALYs, their DALYs, over 40 years. So the multiple outcomes that Colin looked at and with the team. So we have this data, and then as an implementer, I'm like, well, so what do we now do with this? And how do we articulate this to funders, to governments, etc.? And what our experience has been is we were so delighted, but often, whilst we're all being encouraged to take this sort of approach, actually very few people, and myself included, very few people necessarily understand the cost effectiveness work that's being still does a bit feel like it's at times we're putting this really valuable information out to a bit of a void. And I find that, some funders balk at it. They're like, oh, wow, that's a lot. No. And then others, I was saying to colleagues yesterday, I had a joyous call a few weeks ago with a funder who totally understood it, really was able to, compare it to other work that has been done on cost effectiveness, and it made sense, and he was able to put it in context. So I think what's an interesting scenario we're in at the moment, and I don't know what the answer is, and that's why the beauty of Catalyst 2030 is that we're increasingly, people are increasingly doing this work, but how do we make sense of it? How do we articulate it? There are certainly no other, as far as I'm aware, no other peer models of delivering mental health services to kids with HIV to compare with. So there might be other things, but then we're comparing apples and pears. So it's kind of, having done this, what do we now do with it? How do we utilize it? And from our perspective, we're really interested in getting together with groups of people who do understand this, and we can come together and think more about that and make it, really useful, and not necessarily something to be afraid of.
Yeah. No, I think that's a great kind of segue moving forward as well. I mean, thinking a little bit about, it's not just on us to figure out the cost, the impacts, and what the cost effectiveness numbers actually look like in terms of, the bang for your buck, but it's also in terms of actually translating that for a lot of individuals. What does it actually mean? What in this instance, when you're talking about QALYs, you're talking about dailies, talking about Welbies, which I know Barry will walk us through it a little bit. Like, what does that actually mean in practical terms, especially for a funder who's like new to mental health or new to this world, or a high net worth individual that just happens to have a lot of money and they feel like giving it away? Like, how do you explain these types of things to them, right? That might not have a mental health or just a health background in general. So I think it's really interesting that there's a lot of onus to do the work, but then also to explain it and to translate in a way that I think is really unique as well. Sometimes the mental health field, not only do we have to, convince people to give us money, but more often than not, we have to convince them that mental health is worth it in the first place, which is a real big change in our field, I think, in comparison to many others. So it's a really unique challenge. Thanks for sharing a little bit of that. Before we move on to the next question, I just want to double check. Colin, are you back on the call with us? I don't see him.
I have no blue tick on my message to him, so.
Okay, it might have been an internet drop. Okay, let's keep moving on then. So one of the big things that's happening in the mental health space, we all know, is the presence of digital, right? Whether it is the use of digital as a data collection tool, an M&E tool, actually using it as an intervention, using it as a support for an intervention. And there's a lot of cost considerations that come with it, whether it could be beneficial or it could just be honestly a waste of money. It really does depend in terms of like, what is your bang for your buck when you implement something like digital in your programs. And I want to pose a question to Lauren specifically, given your background, your experience in digital. Can you walk us through some of the considerations you've seen when you're trying to assess things like the cost effectiveness of digital mental health solutions, and how do those differ from like traditional interventions?
Yep. Thanks, Christy. And thank you for alluding to like tech can be used in a variety of ways in mental health intervention. So you alluded to this, but to make clear, it can be used to enable a completely person-driven intervention, sort of on the back end operational side to support workers and program managers. It can be a piece of the intervention in terms of training workers or even working with clients in just like a small piece, or it could be the entire intervention itself increasingly, though there's some evidence of that is a little fuzzier, but there's always been sort of some standalone programs that support mental health. So you can think about sort of a spectrum of how you might use technology in your mental health interventions. And then in terms of thinking about whether add tech or use tech into your program, I like to think of it both as, will this tech help improve outcomes? Will improve in some way model fidelity, that people are doing the right thing the right time every time, so reliability? Will it improve the robustness of the delivery by the worker in some way? Will improve compliance, which is not always the nicest word, of patients or clients in your intervention. So will it boost outcomes and the effectiveness side of your intervention? And do you have a good theory of why that is true? Is it solving a problem you have right now? And then also on the cost side, is this, one of the things Damagi does is one of our core products is at its core a data collection and case management tool. Right now, do you have tons of paper you can't keep track of, and it's taking some hours a week to compile the data, right? Like that's a big cost you can reduce potentially with some digital technology, whether it's Damagi's or someone else's. And so thinking about it on both ends of the spectrum, will this help? Because it doesn't always, right? Like sometimes tech can actually just be an increase in cost without a reduction in, it can be an increase in cost with, maybe little effectiveness change. So that's, I think, when thinking about buying a new tech or using new tech, a key thing to look for. And I think just as a field, we should be increasingly looking to see how digital can support existing programs, or in some cases, for some people, replace existing programs. And I work with a lot of academics, and one of the things people are looking at is trying to figure out which digital or standalone interventions work for which people. Because for some people, always a book, self-help book might have helped them get better, right? And are there digital tools for those folks that are even more effective? And for some people, that's never going to work, right? You need a face-to-face counselor or a Zoom counselor or whatever. So sort of the precision bit is a big thing coming out in tech, I think. And I think going forward will improve sort of the scalability and increase access, to more people with the same resources. Fingers crossed, but I'm hopeful.
Yeah, absolutely. Really, if tech can support even a small spectrum of the billion
Exactly.
people in the world that have
Right.
experience, then it's worth investing in. Absolutely, in many ways. I think that's great. I know, Nicola or Barry, any kind of additional things you want to add to that in terms of thinking about digital in your programs and how it relates to how you weigh your cost against your impact?
Want to go first, Barry?
Yeah, I can jump in. I think the key thing with digital that we'll see kind of in the future is just it's going to be very helpful for reducing costs. That I'd be surprised if a digital intervention is going to be more effective than a human intervention. And generally, kind of the research shows that it doesn't really matter that much exactly what kind of therapy you're delivering. Effect sizes are generally pretty similar across all different kinds of therapies. But where digital really comes into play is this ability to reach a huge amount of people for a very, very cheap cost. And so that's where suddenly like the cost effectiveness becomes way better than anything you could do with humans. But we're not there yet. And possibly maybe we won't get there if it turns out there's like you need a human element in the digital program, and maybe humans are a key part of it. But I think lots of people doing lots of exciting projects at the moment, and we just don't have enough evidence to really know kind of what the optimum digital solution looks like yet. but there's lots of exciting work going on.
That's great. Thanks, Barry. Nicola, anything to add to that?
Barry's done it again. He's made it easy for me to follow. I mean, I have the pleasure of being a partner of Damagi and Lauren's team, and we're really learning. You know, very much as Barry's saying, our dilemma is we're a bit conflicted. You know, we want to hold on to this in-person, interpersonal interaction between these 18-year-old peers and their clients. We know it's so powerful, but of course, and I realize I'm speaking to experts here, there's the need to get this out to as many people as possible. How do we, you know, what's the role of digitizing mental health interventions? And so, as I was saying, we're scaling Jandiri. There's the need to get this approach out to as many young people as possible. And so obviously there's a role for digital, and we're exploring through ComCare, and you know, what we've actually done is, rather than a digital delivery, we're using Damagi's ComCare to actually support the peer counsellors to deliver their services. So it's their implementation tools, their counselling guides, lots of child and adolescent friendly resources that are on this platform. So it's more a support tool. Similarly, we're just piloting a chatbot, which is a coaching tool for the peer counsellors. So we haven't, we're not going to the sort of actual intervention as being digital, but digitizing the tools to help this peer do what we know they do best. So what we're really doing is trying to address, you know, the sort of cost of supervision, having humans all over the place to support these peers. Does digitizing some of the support make it more cheaper and more cost effective? But the jury is out, and we're early days, and it'd be great again to keep this conversation going with all of you and learn from all of you.
I think that's a great, a great kind of approach there, thinking about how you're using digital potentially to minimize some of the costs that you're looking at, not just necessarily as an intervention, but as a support system for the intervention that you have that is human-led. And that's quite interesting. And I know there are a lot of those innovation components that we see in grants. And we'll talk a little bit about kind of the practical tips of grants, but I want to get one more question in before we end with that, because I'm just thoughtful of time. So Barry, I want to ask a little bit about some of your experience with the Happier Lives Institute. You've kind of talked a little bit about like the difficulty of evaluating and being an evaluator, for instance, of charities, of mental health implementers. You know, a lot of question around evidence and effectiveness. And I often think about the Happier Lives Institute, which you co-founded, and in some of those early analyses, as especially in group therapy, as a real spark and a real catalyst in our thinking about how to evaluate mental health programs effectively. I know we're still early days though, but I'd love to hear from your experience. Can you walk us through, you know, some of the early lessons learned on cost effectiveness, some of the things that you think about when you're evaluating grant applications, when it comes to things like cost effectiveness or the effectiveness of a program? You know, it'd be great to hear some of your experiences there.
Yeah, sure. Thanks, Christy. So I think the biggest lesson I've learned from when we started off Happier Lives Institute is, although we're doing lots of stuff with numbers, that kind of implies there's maybe some precision and a correct answer, that if you just put the numbers in the machine and crank the handle, it will spit out the correct answer. I think what we've really learned over the last 5 years is, even when you're trying to do these analyses, there's still quite a lot of subjectivity in the choices you make of how to do the analysis. Like, inevitably, when you're dealing with lots of different kinds of pieces of evidence, you have to make a judgment about how those pieces of evidence will be combined. So the challenge for Happier Lives Institute, initially, what they looked at is every RCT that had been done in a low and middle income country with outcome measures related to mental health. But when you look at that literature, so I mentioned earlier, there are different quality RCTs. And so you see, when you look at the effect sizes, it is so spread out. You don't really see this in many other literatures. There's such variety in the effect sizes some of these studies are reporting. So we had to decide, like, which ones of these should be treated as outliers and excluded. So you have to kind of draw an arbitrary line there. But also, even when you've combined all of that evidence from all the studies across the world, you then want to combine that evidence with the specific charity that you're evaluating, and they'll have their own kind of pre-post surveys and other, maybe they've had an RCT specifically of their program. And then you have to decide, like, well, how much weight do we give to these types of evidence? Is the RCT of that charity, does it get like 80% of the weight, 40% of the weight? Or should we actually say, let's look at all of the research as a whole and give most of the weight to that? So there's lots of hard choices to make. So just because kind of you've got an RCT and it spits out a number, you shouldn't be looking at that RCT just in isolation. Everything needs to be looked at in the context of the global evidence base, and also like how relevant that RCT is for the program that you're looking to scale. But certainly, I think a lot of implementers that we look at as well, not everybody has got to that point where they're ready to scale. So the two that we really focused on were Strong Minds and Friendship Bench, which many of you will be familiar with, and they are both scaling, and that they do have strong evidence. There's still kind of uncertainty around that evidence for sure, but there's enough evidence to suggest that they are very cost effective, and that those models should be scaled. But I think people who have kind of not reached that point yet, I think at this stage, before you jump ahead to an RCT, you really want to be innovating and playing around with your model for a while. I think one big question in the field at the moment is kind of how many sessions do you actually need to deliver an effective intervention? Because it might actually, there's research recently showing that maybe just one session can actually lead to a very big effect on people. And often it's very hard to retain people. So it's all about how do you design the first session to be as effective as possible, rather than it just being like an introductory session to a wider program. You have to think about, let's get as much effect out of that first session as we can, because we know we're going to lose people as we go along. And certainly like Friendship Bench have been very successful, but their retention rate is not that great. A lot of people just come for like 1 or 2 sessions and then they don't see them again, but they still get benefit from the intervention. So I think early stage, it's all about innovating, finding out what's working. And then when you get to a point like Strong Minds and Friendship Bench, where you have a pretty settled model that you want to expand to a much wider audience, that's when you really want to test your program with an RCT and get some causal data to actually show that it's your intervention that's having an effect.
That's great, Barry. Thank you so much for some of those lessons. And I think there's some really interesting practical tips there as well. And it keeps kind of coming back to me a little bit, that this whole conversation, even though the definition of cost effectiveness is pretty simple, the whole experience of it, what it means, how to measure it, how to engage with it, how to talk about it, who's going to talk about it with you. We're actually just at the tip of the iceberg when we're actually having this conversation. There's a whole host of information out there. Some of it contradictory, to be frank, hands up. Some of it is contradictory, but it is the reality of our sector. So I'd like to kind of shift us towards some practical tips just before, because I know this is a bit of a tip of an iceberg here. We've got some implementers here from multiple different sizes of organizations. So I want to shift us towards some, kind of maybe key takeaways, but I think I'd rather frame it as like, when you're thinking about, and this will be a question for all our panelists, when you're thinking about fundraising and going to funders, talking about cost effectiveness, talking about costs and impacts, what are some of like the key tips you might have in terms of communicating about it or in terms of fundraising around it? Nicola, I'm going to start with you, bringing your experience in as an implementer and the work that you've done around there. Any tips you have?
Partnerships with people like everyone on this call, recognizing it's a fascinating field, super important, but we couldn't be where we are if it was just Jandiri on its own. Absolutely not. This is I'm speaking today, Colin would have been, as really a team of people, from implementers, those working in mental health. One of our trials was with Friendship Bench, academics, health economists, and then through to how do you articulate that into different audiences. So we're about to publish a paper in a peer-reviewed journal, but we're also putting this together into a 1 to 2 pager for a different type of audience. So my tip would be gathering people around us that can help to brainstorm how to do this, and then once you've got it, how do we get that out there and use it so that it is effective, and then just to keep learning from it. I mean, I put in one of the questions in the chat. You know, we've already said, gosh, and put this in the paper, that we've likely really underestimated the cost effectiveness, because actually when we look at this peer card, they're certainly impacting on mental health outcomes and HIV. But what about, someone mentioned the effect on the health system and healthcare workers, and the work that, you know, this task shifting approach is the impact of that on the broader ecosystem. So it certainly doesn't stop here. We're now thinking, well, the model's being replicated in other countries. They're using different costings. For us, one of the key cost drivers is, what do you pay a peer counselor? And in Zimbabwe, it's very different from in South Africa. It's very different in Cote d'Ivoire. And so that's going to be one of the key cost drivers. So what we say in Zimbabwe might be quite different in South Africa or Rwanda or South Sudan. So this is just the beginning, but then do we want to do an RCT in every country? So I feel there are many, many questions coming.
It's a huge piece of work. You can have an entire team. A can of worms, exactly. An entire team to focus on. I've just actually noticed Colin, I think, is back online with us.
Oh.
So Colin, if you can hear us, I'm going to ask you this kind of specific question, if you don't mind jumping in. What is, you know, when actually conducting the cost-effective analyses that you've done in the past, do you have one particular tip, let's say, for an implementer, like a partner like Shandiri, for instance, to look for or to think about when they want to conduct a cost-effective analysis?
Yeah, so sorry, I dropped out, people. The network where I am is very bad, so I had to shift to another place. Let's see. So I think just as you were asking, there was a break in what you were saying, but you were asking for any tips that I could give. Okay, tips, let's see. That kind of got me off guard there. I think it's difficult, as Nikolai has been repeating about how not everyone is able to conduct an RCT to be able to evaluate their programs or interventions. I think maybe there is still some scope to be able to maybe embed you know, like a cost data collection process into regular or normal programming. I think at times when we make decisions to evaluate cost and cost effectiveness, at times maybe life gets complicated as we try to retrace our footsteps. Maybe it's a retrospective costing, trying to find certain cost data, certain outcomes data. But maybe if I've been in groups or on groups where the attempt is to make cost data collection a routine thing, where it's part of the normal programming, and people can from time to time be able to reach in there and extract the data that they need, both in terms of the cost and the effects. Yeah, I think at the moment that's what I can think of.
That's great.
I don't know if I answered the question.
Yeah, no, Colin, that's great, and thank you so much for hanging with us and moving places. I know the internet's been tough for you today. Right. I think that's awesome. You know, Nicola, you were mentioning it can feel like a can of worms in terms of what you're opening up, but actually, if you can just, especially as a starting point, start small. Just collect cost data, right? Think about, you know, and start to think thoroughly about what your costs look like and what it means to actually implement your program. Do a cost data analysis. Do do data cost collections and go through that process. For instance, starting small is a great tip, I think, in terms of even just breaching the tip of the iceberg, if you will. Lauren, I'm going to hand. Oh, sorry. Go ahead, Colin.
Sorry, Christy. Just to add, I think PSI has kind of done a good job of what we're talking about here. I've seen some of the work where they're reporting on costs of certain programs because they've tried to make this sort of thing a routine kind of analysis with their program. So perhaps it's something that just to show people that it is actually doable.
That's great. PSI. Okay, absolutely. If you have a link to anything there that you can share in the chat, that would be great. Great for folks to see. Okay. That's awesome. Lauren and Barry, I'd like to just wrap up with you guys. Any tips you guys have? Lauren, we'll start with you.
Yeah, so I just put this in the chat, but briefly, I mean, a lot of we rarely have an RCT about exactly what I'm talking about in a grant, right? And so if you're talking to a research-minded funder, which is not all of them, right? Some are really, really into hard data numbers and some not as much. So definitely know your audience. We can pull sort of very thoughtful evidence from other organizations, explain with very clear logic and theory why what we're doing should get similar outcomes, and sort of just show deep thinking and logic into why, in theory, about why your project will work, and some supporting evidence, as well as showing how you're going to collect costs, right? And I just also want to point out, even the most data-minded folks, I worked on a scoping grant to GiveWell, which was awarded, and GiveWell is very data-driven. Even, a huge percentage of their analysis is estimates. And there's a lot of guesswork and a lot of, very educated, highly thought out guesswork, to be clear, but there's a lot of estimation in there. So don't get too scared that your data isn't perfect, because really nobody's is, particularly in mental health. So don't let perfect be enemy of the good. Be really thoughtful and logical. Use supporting evidence. I sound like I'm talking to people writing a term paper in college, but it's true. And some people really won't want that hard, perfect RCT data, but in my experience, that's rarer than just having a really good, thoughtful approach with solid evidence and a clear plan, both operationally and implementation-y, and why it'll work.
That's great. Thanks.
And then
Lauren.
you cross
Very
your
practical.
fingers. But
yeah, exactly. Yeah. Do what you can. Cross your fingers. Fight like hell. Barry, over to you.
Yeah, I think that's really good advice from Lauren. And I would say, if you don't have your own RCT data, what you should have and what you should do to really understand your program is do some kind of literature review. Have a look around what RCTs or papers have been studied about this intervention. This is the story of Strongmind. Someone had done an RCT in Uganda of interpersonal group therapy. Sean Mabry read that paper and he said, right, well, why is no one kind of trying to spread that across Uganda if we've got evidence? So he didn't kind of do an RCT initially. He was saying, look, there's an RCT already in Uganda that shows this can work. So yeah, it's really important you understand the wider evidence base around the world. And I think also Lauren's right, there are different types of funders. Some are more interested in the numbers and some are not. But I think regardless of the funding perspective, just as someone who is trying to implement a really good program, you want to be caring about cost effectiveness regardless of whether it leads to funding or not. You want to be really on top of your numbers. Have you minimized your costs as much as possible? Have you extracted the maximum effect you can from your intervention? It's kind of the fundamental of running a successful project, I think. So it matters for everyone. Yeah.
That's great. And I think with all of those tips, we really covered a broad range. And I think we've answered quite a lot of the questions in the chat as well. And thanks to the panelists for going in there and responding to them, because we've rapidly run out of time. Nicola, I'm going to just hand it over to you because your hand is up, and then I'll bring us home.
I'll be super quick, just to clarify or qualify the background to our RCT. In 2016, WHO were trying to develop a guideline for mental health and psychosocial support for adolescents with HIV. They couldn't pass one because there was no rigorous RCT data to confirm that this was needed. And so that's the kind of where we were coming from. There was nothing. So we did the RCT, and there is now a guideline recommending this for all adolescents with HIV. So would we do an RCT again now in all these other countries? I think, as everyone's saying, there are RCTs out there now that other people could draw from. So it's just, our experience is where we were coming from. There was absolutely nothing to kind of compare with. So I just thought I should share that.
I think that's great, and thanks for qualifying that, Nicola. I'm sorry, folks, we didn't get a chance to live answer your questions, but thank you so much to our panelists, and thank you so much for responding to those questions in the comments while we were going. Your multitasking abilities are stellar, so appreciate you. Just to kind of quickly sum it up briefly, I mean, cost effectiveness is this big iceberg. We're just really breaching the tip of it. I hope today we really were able to share a few tips and thoughts in terms of what it means. Some of the takeaways that I have, know what's important to your context, know what's important to your culture, measure it as best as you possibly can, find something to compare it to if you can. If you can do an RCT, that's awesome. And then write about it and fight like hell to get the money that you guys need in order to continue to implement and do the great work that you do. It's definitely not that simple, but that's some of the takeaways that I have here from the group. So thank you again to our panelists, really appreciate it. And thanks everyone for joining us today. We have our third webinar on November 5th. We will take some of this stuff and we'll talk a little bit about how to turn it into money. We'll talk about fundraising plans, funder relationships, strategic partnerships. So please do join us. And I hope you guys have a happy Mental Health Day tomorrow. You guys celebrate, hopefully, mental health at work. And I will hand it over to Chris.
Thank you very much indeed, Christy. What a great session, eh? Don't you think? Well, I guess you're the moderator, so you can't really say it other way. But
I had a great time.
There you go, that's good. No, I think it's been a really useful session. It's been wonderful to see all the people gathered here, friends and members of the collaboration. And good to see Dick there at the end. Richard, hi, Richard Doherty. Good to see you there. And it's been great to have a lot of the questions copy and pasted into the document, and also to see them being answered on the chat. Really good. So I just want to say thank you very much. We look forward to seeing you for the final part of the series in November, as Christy has already outlined. And I want to join you, Christy, in thanking Barry, Nicola, Colin. We're sorry, Colin, we didn't hear more of you, and Laura and Lauren. And we look forward to getting back together in November. All the best for now, and many, many thanks.
Thank you, everyone.
Thanks, everyone.